Thank you, Linda. Ladies and gentlemen, and it's a great pleasure to present to this, and always a challenge to follow two such good speakers. I've got EAU on here because you asked me to talk on the European guidelines, and also the presentation at the end is based on abstracts which have been presented to the EAU earlier this year. These are my conflicts of interest. Obviously, we're talking about overactive bladder, and I know everybody in the room appreciates what this is. Of course, defined by this organization, but clearly different from bladder overactivity, which, as you know, particularly in women, only occurs in 40 to 60% of the female population, whether they're dry or wet. And so I'm always concerned when I go to general meetings and everybody thinks that overactive bladder and detrusor overactivity are the same thing. And clearly, if one looks at this, as we've already seen this slide, urgency, which is a sensory symptom, drives the complex, as we've already heard from my two scientific colleagues. So the sensory mechanisms are important, and the whole definition is based on the original description from the ICS of 2002, and very little has changed since then, where you get an increase in urgency, which clearly is something which is experienced at the level of the limbic system based on afferent feedback, which is coming up through the periaqueductal grey matter. Now, obviously, when one's thinking about overactive bladder, one needs to consider the various components, the patient's complaints, which of course are preeminent in importance, the patient's expectations, and of course, as urodynamicists, this is what we do when we carry out a urodynamic study. We need to think about our own knowledge and perception, which of course influence things, as one of the doyens in this area, Turner Warwick, defined when urodynamics was introduced, the bladder is an unreliable witness. And clearly the symptoms that we see from patients aren't necessarily related to the underlying condition. Patients experience them in different ways, and as clinicians we all have our inherent bias, how we choose to take a history and interpret them. So clearly you have varying perceptions and varying expectations in the population. Now, we've already heard very elegantly from my two colleagues the traditional approach, but clearly I know this room doesn't believe in that any of these drugs act directly on the detrusor. That's been clearly shown by the work of my colleagues here. Although it's very nice to think that you're affecting the detrusor muscle, as Laurie Berder has shown over the years, there's quite an influence, and also Carl Eric, on potential release of putative neurotransmitters. And Carl Eric's model, for instance, of oxyhemoglobin, which equates with so-called clot retention in the human, where you get intense spasm of the bladder, makes a lot of sense. Now, as clinicians, we love to think of the detrusor muscle, and it's very nice to think the drugs are relaxing the detrusor. As has already been mentioned, very clearly, it's a bystander effect. If you give enough antimuscarinic, you'll go into retention. If you give enough Botox, you'll go into retention. But if that's the case, how does sacral neuromodulation work in the same way as a third-line therapy, even more effective? And of course, tadalafil, which acts in a similar way potentially, although we don't know the exact mechanism, and is similar to an alpha blocker for the male in terms of effect on lower tract symptoms. So clearly, there's a lot happening which we don't fully understand, but the work of our pharmacological colleagues has made that clear over the years. Now, obviously, it's very important to think of evidence base. And one of the problems, of course, is that many guidelines fall out of really become obsolete, and there's an iteration as the years go on. Now, obviously, you look at the latest guidelines, it's very important to realize that clearly antimuscarinic is effective. We all know that. There's strong evidence for that using the GRADE methodology. We do know in the elderly, because of other anticholinergic effects of drugs, often ones which we don't appreciate have anticholinergic effects, that there's a potential, as Adrian Wag and others have shown from their work, for significant impact on cognitive function, although poorly studied in the various studies that are out there. We do know that most patients will stop antimuscarinic therapy, and possibly to a lesser extent beta-3 agonists, but the persistence at best with these drugs in real-life practice is around 40%. We do know that the beta-3 agonist, now the latest guidelines, suggest similar efficacy to an antimuscarinic, and combination therapy, of course, is something that's been looked at. The EAU guidelines have also tried to look at numbers need to treat as one way of looking at this, And of course, the literature is crammed with meta-analyses on the subject, trying to compare and contrast the effect of these drugs. So looking beyond this, can we improve this situation? Well, a gentleman called Professor Larry Phillips came to see me from the London School of Economics about 9 months ago. And based on this, we set up a guideline panel via the European Association of Urology. Now, the problem is, of course, the traditional model for looking at drug therapy is to think about favorable and unfavorable effects against placebo. And of course, then you have to try and interpret and level the playground using a meta-analysis. Now, that's a very effective way of looking at things. It's a basis for contemporary evidence in the guidelines. But can you improve on this? Well, of course, there are multiple ways in which you can actually compare data. And this just demonstrates the complexity. But taking the area which I highlighted in red, there's a technology which has been introduced, and it's not new. We go back to the 60s for this. And it's been used in the pharma industry. It's called multiple criteria or multi-criteria decision analysis theory. The principle is to extend decision theory to accommodate multiple conflicting objectives. And it's best for looking at problems dominated by multiple effects, providing a common unit of preference value for both benefits and risks, using the evidence that exists, but also using a subjective interpretation, which you can criticize like anything, but at the end of the day, everything we do has got a subjective interpretation of objective parameters. And the gentleman who set all this up is a gentleman, as you can see from the States here, Professor Reifer, who described the spirit of decision analysis is to divide and conquer, really to decompose the complex issue looking at data. And this is all based on a Bayesian model using statistics, which I certainly don't understand and which clearly is quite complex. It's led on to a way in which you can analyze data. Of course, you need to think of the context, the alternatives, the criteria. You need to weight things, which you can criticize. You need to then score issues, look at the results, and then you can use sensitivity analysis and provide recommendations. So the principle is to take a group of people who've worked in this area, like myself, not explain to them what you're trying to achieve, but to put them through a process whereby you select the criterion parameters which people think are important based on their experience and knowledge. To develop an effect tree, select the weighting methods which you can use and to try to normalize the data to, say, 100, to validate and look at swing weights and so on, so you can look at different agents within the analysis, and then to perform a sensitivity analysis. I'm sure none of you would disagree with the fact that these are the common favorable and unfavorable effects that we see with drugs. You may criticize me and say it doesn't have cognitive dysfunction in there. But that I'm not aware is in any of the studies, placebo-controlled studies, which has been adequately validated. And this analysis is based on all of the placebo-controlled studies in this field, which have been looked at by the EAU Guidelines panel and which have been used for pivotal decision-making by the pharma industry. Now, what about the principle? The principle is to look, if more green, there's more benefit, and more red, more safety. And this is a way in which you can then compare different trials. Now, of course, there's a downside. All trials have different populations, slightly different criteria, but most of the pivotal studies have similar criteria, although the populations are different, even though the age groups are very similar across the board, with a mean age around 58 to 60, with a predominance of women, of course, over men in the trial. So what you could then do is to look at the favorable and unfavorable effects on the left-hand side, on the y-axis, and what you do is to get the panel to score what they think the importance of favorable and unfavorable effects is, just in isolation from the exact data. Then you can add that up and then normalize those different components to a 100 scale on the far right, on the y-axis, and you can see the absolute values for, say, placebo, drug A, drug B on the bottom there. You can then do a sensitivity analysis, which I have some concerns about, because at the end of the day there's a lot of subjectivity, but you can move parameters so you can actually look at whether one drug is better on, say, urgency, another on urgency incontinence, and of course, you can easily criticize that. And you can see, using the example that I showed, you can do a sensitivity analysis and come out with further data. So the aims of the study were to assess the benefit-risk profile of all of the drugs and treatments options which are out there for overactive bladder at present. This does not include third-line therapies such as onabotulinum toxin, but looking at the oral drugs, and does not include tadalafil, which has never really been looked in this area except in the male, where there's one study because of European criteria when it was introduced, comparing it to tamsulosin. So I didn't think that was relevant in this context, and it's not part of the OAB guidelines. And a sensitivity analysis could then be performed, which I'm not going to go into detail on, because I feel that trying to say one drug over another's better at urgency and so on is in the realms of marketing. The MCDA model was then adapted from the existing criteria, and this is something that's been validated by the Medicines Agency in Europe and has been used by different organizations, particularly in submissions. So basically, the study design was to look at the efficacy and safety data from published randomized placebo-controlled trials for antimuscarinics and the beta-3 agonist that exists. And of course, there is a second beta-3 coming along. We didn't have valid data at that stage to include. To compare the 14 common drugs or drug combinations which exist, and then to look at these parameters to judge the most likely to affect patient outcomes and to try and rank them based on the data, as I've mentioned, used at the EAU Guidelines panel. And then a sensitivity analysis, which, as I've mentioned, I'm not going to focus on. So if one takes the favorable and unfavorable effects, if you look across the board, this is how the data looks. As I've explained to you, this is the way in which the analysis was carried out. On the far left, you can see the side effects and the benefits which have been defined. I've included here drugs which are against placebo. There was one study which was using fesoterodine against placebo, which is a slightly unfair comparison, but nevertheless very effective. We're using flexible dosing. There are other drugs which have used flexible dosing, and the importance of that is to demonstrate personalizing medicine, so you can dose patients with different doses of a drug to improve their outcome. But you can see very clearly there that gives you a pictorial description, and you can see where placebo lies. Of course, we appreciate placebo has unfavorable and favorable effects. You can do a sensitivity analysis, and you can see that using that you can use the various criteria to move the parameters and assess drugs based on individual symptoms. So really, to conclude, the MCDA model I think is quite useful, giving a different perspective to a standard meta-analysis. It allows you to provide clinicians with a different way of looking at things, and obviously to conclude that a combination of true drugs with different mechanisms of action may improve efficacy to an extent, but also that flexible dosing with the drug which I showed there may certainly improve outcomes for individuals. And I hope at the end of this session I don't leave you with too much of a headache. Thank you.